I'm Dr. Larry Dean, the director of the University of Washington Medicine Regional Heart Center. I'd like to welcome all of you to the University of Washington Regional Heart Center Grand Rounds this morning. For our first presentation, Dr. Michael Chen, a member of the Division of Cardiovascular Diseases at the University of Washington School of Medicine, will present our first case. Dr. Chen.
Thank you, Dr. Dean. A 62-year-old male carpenter was at work at a construction site when he fell to the ground unconscious. His friends began bystander CPR and flagged down a passing fire truck. The cardiac monitor showed ventricular fibrillation. A single electrical shock defibrillated him to sinus rhythm. He was intubated and brought to the emergency room at Harborview Medical Center. His initial post-defibrillation ECG was basically normal. In the emergency room, the patient was intubated and unconscious, sedated on the ventilator. His heart rate was 110 beats per minute. His blood pressure was 120/80. He had sustained a laceration to the back of his head with bruising behind his left ear and neck sustained from his collapse. The remainder of his exam was unremarkable. This is his initial electrocardiogram in the field, which is essentially unremarkable. However, upon arrival in the emergency department, a repeat ECG was quite remarkable for ST elevation here in the anterior leads and ST depressions reciprocal in the inferior leads. The patient was started on a cooling protocol for neurologic protection. A CAT scan of his brain showed a possible contusion of the frontal lobe, but no evidence of intracranial hemorrhage. The patient was taken to the cardiac catheterization laboratory for coronary arteriography and primary angioplasty for acute myocardial infarction. I'd now like to introduce Dr. Stephen Goldberg, interventional cardiologist at the University of Washington, to present the remainder of the case.
Thank you, Dr. Chen. Coronary thrombosis is the cause for the classic heart attack or myocardial infarction. This is a syndrome which is so prevalent in our society today, but it's rather remarkable to realize that it's only been recognized as a clinical entity for about 100 years, first having been described formally by Dr. James Herrick in 1912. Despite its rather recent onset into the presentation of the world, it's a remarkably prevalent condition occurring in approximately 850,000 myocardial infarctions per year in the United States. In fact, myocardial infarctions and coronary artery disease is the single largest killer of American men and, recognized more recently, of American women. A statistic is that on average an American dies of heart disease every minute. ST elevation myocardial infarction, represented in this particular case, represents about 35 to 45% of acute coronary syndromes, that is, presentations of chest pain due to heart disease. Now, it's interesting that most patients who present with this type of classic heart attack do not have any symptoms prior to this, such as angina pectoris. Now, we now have some information that the patient being presented here actually was complaining of chest pain for several days to a week prior to this event. However, he did not recognize this as cardiac symptoms and did not seek medical attention. This is his coronary arteriogram, which is fairly characteristic of this type of ST elevation myocardial infarction. This is an injection in the left coronary artery, and what we can see here is that the major branch of the left coronary artery, the left anterior descending coronary artery, right there, has a cutoff sign where it's being occluded by thrombus or a blood clot. This had a significant impact on his heart function, with this representing his left ventriculogram, which shows a marked impairment in his left ventricular function with a significant wall motion abnormality in the anterior wall here, the apex, as well as extending out into the inferior wall with impairment of overall cardiac function. Well, I stated a moment ago that blood clot or thrombosis was the cause of acute myocardial infarctions, and this was actually hotly debated throughout the 20th century. It was only when trials comparing clot-busting medications or thrombolytic treatment were done that the proof of concept that clotting caused this was laid to rest. Now, these trials, there have been several of them, and they were put together in a meta-analysis of all the larger studies, comprising over 60,000 patients in the meta-analysis seen here. And in these 60,000 patients, there is an 18% reduction in mortality when thrombolytic therapy is used compared to controls. But there's an alternative way of treating this type of myocardial infarction. This is with mechanical opening up the vessel or reperfusion therapy and using a coronary angioplasty procedure, as was done in this particular case. This is the same coronary arteriogram that I showed you a few moments ago, just in a slightly different orientation. And this also showed, of course, since it's the same vessel, a cutoff of the vessel seen right here. With the administration of aspirin and heparin and the placement of a small guide wire, 0.014 inch, across that obstruction, the obstruction was relieved, leaving behind a high-grade narrowing seen here, about a 90% stenosis. One can speculate that that stenosis was present prior to the presentation and that it was this stenotic narrowing which led to the symptoms of chest pain the patient was suffering before he had his myocardial infarction and his cardiac arrest. This was further treated with a device to remove any residual thrombus, and then a stent, a metal scaffold, was implanted over a balloon, seen here, to scaffold the vessel open and relieve that obstruction. And this is the arteriogram after the stent was implanted, showing no evidence of any residual obstruction and excellent flow throughout the vessel. Here then is a before and after picture of the obstruction seen on the left and of the widely patent or open vessel seen on the right after it was opened up, a very extensive artery. Well, we've mentioned two different means of opening up arteries at the time of acute myocardial infarction. The first one is thrombolytics, and this has the advantage that it is easy to deliver because it's an intravenous medication. Because it's an intravenous medication, it's therefore widely available and is present in virtually every hospital. However, there is some limited applicability of this particular form of treatment. For one thing, the clots are not responsive to these clot-busting medications if they have been in place for too long. So after about 6 hours, the therapies tend not to be too effective, and after 12 hours, there's no evidence of any benefit of giving thrombolytic therapy. Furthermore, because they are powerful clot-busting agents, they also have the downside of potentially leading to bleeding complications. The alternative treatment to open up the arteries is mechanical, using angioplasty. This has a disadvantage that it requires sophisticated equipment and specialized expertise, and therefore is less available. Only perhaps about 39% of hospitals in the United States can provide routine angioplasty. However, as I'll show you in the next few slides, it does appear to be more effective, both acutely and long-term, compared to thrombolytic therapy. It would seem that it has greater upfront expense in order to have the specialized equipment and so forth, but it turns out that because it reduces later-term complications, that it's a highly cost-effective treatment. Well, there have been several studies that looked at comparison of thrombolytic versus primary angioplasty. 23 studies were recently presented in a meta-analysis of all of these studies. There was a significant reduction when angioplasty was used compared to thrombolytic therapy. That's both at a 30-day endpoint and at a 1-year endpoint. In fact, the benefit of angioplasty appears to be so strong that even if there is a delay in treatment in order to transfer the patient to a hospital that offers angioplasty, it still seems to be more effective than giving thrombolytic therapy. In 5 different studies which have done this comparison, there was a trend towards a reduction in mortality, but a significant reduction in repeat myocardial infarction, in stroke, and in the combined endpoint of death, myocardial infarction, or stroke if patients were transferred to hospitals with angioplasty capabilities. Now, this is limited by the time necessary to do the transfer, so somewhere the transfer needs to be able to occur within somewhere less than an hour or 2 in order for these data to hold up. Well, despite the benefit of angioplasty as a means of achieving reperfusion with ST elevation myocardial infarction, it's actually rarely employed. The National Registry of Myocardial Infarctions is a volunteer registry of hospitals who take care of patients with heart attacks, and they've identified that primary PTCA, or angioplasty, is used in a very minority of situations, less than 20% of the time. Although this is increasing over the years, it still remains to be used quite a bit less frequently than thrombolytic therapy, which is used about 5 times more commonly. Now, most concerning, however, is the fact that a high percentage of patients who are eligible for reperfusion treatment for the acute myocardial infarction don't receive anything. That is 30%. Another registry called GRACE, the Global Registry of Acute Coronary Events, has come up with almost identical information. That is, 30% of patients who are eligible for reperfusion due to their ST elevation myocardial infarction do not receive any form of reperfusion. And angioplasty, the preferred modality, is used much less frequently than intravenous thrombolytic therapy. So the question is, why are patients not getting reperfusion therapy? And there are several possible explanations. First is that, of course, the clinicians are doing the right thing because the patients have contraindications or comorbidities. In the case being presented today, the individual had suffered head trauma from his fall, and therefore it would have been contraindicated to give him a thrombolytic treatment because of the risk of bleeding inside of his brain, which would have been present. If primary angioplasty had not been available, therefore, then it perhaps would have been an appropriate thing not to offer any reperfusion treatment. Another problem is that many patients with acute myocardial infarction present without any chest pain, and therefore it's difficult to know when their heart attack is starting. If you don't know when it's starting, therefore you don't know what is the appropriate window for giving these thrombolytic treatments. And as mentioned before, if more than 12 hours have gone by, there's no benefit of thrombolytic therapy. Angioplasty probably will work in the longer period of even beyond 12 hours. However, as mentioned before, angioplasty is less available. As mentioned, some hospitals, the therapy may not be available for a variety of reasons. And however, concerning to all of us is whether or not there are missed opportunities. Are physicians sometimes failing to make the diagnosis in appropriately timed fashion, or once they've made the diagnosis, are they failing to institute the appropriate treatment? And we don't know how prevalent that is, but that is something that everybody's interested in trying to understand. Well, there are several ways to try and increase access to primary angioplasty, the preferred modality in patients with acute myocardial infarction. I've already mentioned one, which is transfer to a hospital with angioplasty capabilities. But another strategy has been achieving a certain amount of scrutiny and consideration, which is to attempt to expand capabilities of available diagnostic cardiac catheterization laboratories who are not performing angioplasty as part of their routine, but expanding them to allow primary angioplasty even though those hospitals do not provide cardiac surgery backup. Traditionally, angioplasty is only done in centers where if a complication occurs, the patient can be rushed off for emergency coronary artery bypass graft surgery. With the advent of stents, that has become a very infrequent occurrence. And in fact, a recent registry of hospitals doing primary angioplasty without cardiac surgery backup only 0.4% of cases did require emergency bypass surgery. So it's very uncommon for that to be needed. Therefore, the argument has been made that if the appropriate equipment and the appropriate experienced personnel is available, then perhaps those hospital cath labs could be used to perform primary angioplasty. This is being highlighted in this particular case because the patient was brought to Harborview Medical Center, which is rather unique in the city of Seattle because Harborview is the primary trauma center for the entire city of Seattle. Therefore, it is the routine location for paramedics and ambulances to bring the sickest of the sick patients. And in order to provide optimal care for those that are brought in under these circumstances with an acute myocardial infarction, the diagnostic cardiac catheterization laboratory at Harborview was expanded to include primary angioplasty. Now, elective angioplasty and cardiac surgery for patients at Harborview are done at the University of Washington. Now, this may expand the primary angioplasty significantly throughout the country because 68% of hospitals in the United States have cardiac catheterization laboratories, but only 39% have cardiac surgery. So there is the potential that we could be doing much more primary angioplasty. I mentioned a moment ago the use of intracoronary stents, and they've been a major improvement in the performance of coronary angioplasty for a couple of reasons. First of all, they make the initial angioplasty results more predictably successful because they scaffold the artery open and prevent it from closing down acutely, leading to complications. Furthermore, stents are important in diminishing the vexing problem of restenosis that occurs after balloon angioplasty. Restenosis is the scar tissue formation and scarring down of the vessel, causing it to re-narrow down, leading to recurrent impairment of blood flow to that part of the heart muscle, causing symptoms such as chest pain or shortness of breath, and requiring repeat angioplasty or bypass surgery. This restenosis process occurs several months after the angioplasty procedure and is diminished when stents are employed compared to balloon angioplasty. However, because we are placing a foreign body inside a vascular space, there is the potential for the body to react negatively to this foreign object and promote clot formation. This problem of stent thrombosis, or clotting within the stent, can be a devastating problem, leading to an acute myocardial infarction, much like the one presented here today. This is a picture of a vague outline of a stent seen here without contrast going through it because of the fact that there is clot that is occluding this stent. Now, this problem of stent thrombosis is seen in about 1% of stenting procedures. It's a significant problem, however, is relatively infrequent. But when one considers placing this stent in an artery that already has thrombus in it, there were initially concerns that this might promote further thrombosis, and therefore there was some reluctance early on to use stents in the setting of acute myocardial infarction. However, several studies looked at this very issue and found that when stents were used, compared to plain old balloon angioplasty or POBA, that in fact the outcomes were improved. Now, there were no differences in death or myocardial infarction between the two groups, but there was a significant reduction in patients coming back several months later with recurrent symptoms requiring another angioplasty procedure or bypass surgery known as a target vessel revascularization. This was significantly improved when stents were employed in this particular setting. Well, we live in a world of constant change in many ways, and angioplasty is no different in that sense. And we are currently in a new phase of angioplasty where we have new technology to reduce the problem of re-narrowing inside stents. And this is when we can put a drug on top of a stent to mimic, or to prevent, rather, the scar tissue formation from developing. Now, this is a postcard from Easter Island. These are the classic statues that are seen on the beach at Easter Island that people flock to visit. And in the soil of Easter Island was discovered a substance coming from a bacteria. And this substance has unusual characteristics. It's both an antibiotic, it's also anti-inflammatory, and it has anti-proliferative characteristics. That is, it can reduce the scar tissue formation. And therefore, some early investigators thought that perhaps placing this substance on a stent might prevent scar tissue formation within that stent. Now, because this substance was found in Easter Island, which is known by the natives there as Rapa Nui, this substance is called rapamycin. It is, along with another substance known as paclitaxel, which comes from the Pacific yew tree here in the Great Northwest. These are two substances which have been found to be significantly effective in reducing restenosis inside stents after coronary angioplasty. And this was demonstrated in two large studies of over 1,000 patients, one with rapamycin and one using paclitaxel, where patients were given either a bare metal stent or a stent covered with one of these drugs and were then followed for 1 year. And there was a significant reduction in the 1-year event rate using either of these agents. And that reduction in event rate was almost exclusively due to a prevention of restenosis or re-narrowing of the stent, leading the patient to come back with recurrent symptoms for another angioplasty or a bypass surgery. Well, with any new technology, there are always concerns about what's the downside. And there are a couple of considerations with drug-eluting stents. First of all, is the results durable? Sure, there's a benefit at 1 year, but does it extend out beyond that? And early in our experience, of course, we cannot provide that information, although the early information does look promising. A second problem is, are there potentially any downsides that we don't yet recognize? And because these drugs prevent a healing response inside the stent, and therefore potentially exposing this bare metal to the blood surface for a longer period of time, there were theoretic concerns that this might promote increase in clotting inside the stents or stent thrombosis. So with early reports of stent thrombosis occurring, the company contacted the FDA, and this actually made its way into the mainstream media, shown here by this New York Times article of July of 2003, warning that perhaps drug-eluting stents might be associated with stent thrombosis. Well, this has been looked at very, very closely, and over 15,000 patients have been examined, both in randomized trials and in careful registries. And in these 15,000 patients, the incidence of stent thrombosis is 0.8%, which is roughly what we might expect using a bare metal stent. And therefore, the initial impression is that this is not associated with a higher risk of stent thrombosis, but this is something we continue to watch very carefully. I think that this reflects a problem that we have with trying to practice medicine in a rapidly changing world, this dynamic tension of two competing theories. One theory is that we should rapidly adopt cutting-edge therapies, even in settings which have not yet had the opportunity for those studies to be performed. The other theory is that we should be conservative and wait for evidence-based and use an evidence-based approach, waiting for the studies to be done in each of these specific subsets. In other words, should we wait for definitive proof for each condition or extrapolate data to as yet unstudied populations, such as patients presenting with acute myocardial infarctions, in the delivery of this new technology of drug-eluting stents? So in our patient, an appropriately sized rapamycin-coated stent was implanted after suctioning to remove any extra thrombus. The ST elevations on his electrocardiogram resolved immediately, and here's his electrocardiogram, which is actually fairly normal with a little bit of artifact from movement. And here's a before and after showing the dramatic ST elevations seen over here and having resolved completely on his post-procedure electrocardiogram. In follow-up, the patient remained comatose for 3 days but showed rapid improvement and was discharged 7 days later. It is now exactly 2.5 weeks later. I called the patient up a few days ago just to find out how he was doing. And I mentioned that we were going to be telling his story at the conference today. And he immediately insisted upon coming here today so he could hear the presentation. And if he'd be willing to come on up here and tell us how he's doing, I'd like to invite him up here and let us know.
All right.
Thank you very much for coming.
Thank you, doctor.
How are you doing?
I'm doing great.
Good.
Yeah.
Good.
Back to work already, and not on the same job though. But yeah, I feel great. I'm paying more attention to my stress level though, and my diet, which is real important.
Now, there was the story that you were having chest pains before the procedure. Do you remember what those were like?
Yes, they were upper chest pains here, like a lot of gas, but it was up in here, and that was for approximately 2 days before.
And what did you think was going on?
I thought my stress level was really high on that, and but I just thought it was gas.
It didn't occur to you this might be a heart problem?
Nope.
Okay. And have you had any more of those symptoms since you've been discharged from the hospital?
No, not at all.
Okay. Now, you said that you've gone back to work.
Yes.
What type of physical activity have you been engaged in?
Well, it's been varying a little, because as I got on my pills and that, the first few days I didn't work and that, and then once they started kicking in, we went back to work slowly, and I'm mostly letting the other guys do the work and that, although we did move a very large piece of wood the other day, and required a lot of physical activity on my part also. And
Well, that's a remarkable story, and I think you've done tremendously well, and I very much appreciate your coming here to talk to us today.
actually, this was great. I mean, it's serious. I mean, this was very educational and answered a lot of questions I had.
Good, good.
So, thank you.
Thank you
Appreciate
very
it.
much.
Okay.
In conclusion, coronary angioplasty is highly effective in the management of acute myocardial infarction. Limited availability makes angioplasty less common than thrombolytic treatment. Coronary stenting reduces the restenosis after primary angioplasty. The role of drug-eluting stents in the setting of acute myocardial infarction requires further studies, but initial series appears to show it to be a safe strategy with the potential to improve late-term outcomes. Thank you all. Appreciate it.
I'd like to thank our audience for their participation today, our presenters for their participation as well. I look forward to seeing all of you at another Grand Rounds in the near future. Thank you very much.
Thank you.